Praise be to Allah, the cherisher and sustainer of the worlds. I'm Dr. Ramsha Mushtaq Khan, and today I have the opportunity to briefly discuss the topic malnutrition under the kind supervision of Professor Dr. Saira Afzal. A hungry stomach, an empty pocket, and a broken heart can teach the best lessons of life. Content outline. Number 1, malnutrition, its definition and forms. Number 2, concept of food gap, web of causation of malnutrition. Number 3, levels of prevention and modes of intervention. And number 4, growth monitoring and nutritional surveillance. At the end of this presentation, the participants will be able to define malnutrition and identify its forms, understand the concept of the food gap, identify the management protocol of an individual with malnutrition and recommended strategies for its prevention, develop an understanding of the differences between growth monitoring and nutritional surveillance, and recognize the global recent advances in the context of malnutrition. Malnutrition is a pathological state resulting from a relative or absolute deficiency or excess of one or more essential nutrients. It comprises of 4 forms. Number 1, undernutrition. Number 2, overnutrition. Number 3, imbalance and specific deficiency. Undernutrition is a condition which results when insufficient food Undernutrition is a condition which results when insufficient food is eaten over an extended period of time. In extreme cases, it is called starvation. It is not only an important cause of childhood morbidity and mortality, but also leads to permanent impairment of physical and possibly of mental growth of those who survive. The term encompasses 3 frequently encountered problems. Number 1 is wasting, which is also called acute malnutrition. Number 2 is stunting, which is also called chronic malnutrition, and underweight. Overnutrition is a pathological state resulting from the consumption of excessive quantity of food over an extended period of time. The high incidence of obesity, atheroma, and diabetes is attributed to overnutrition. Imbalance is a pathological state resulting from a disproportion among essential nutrients with or without the absolute deficiency of any nutrient. And specific deficiency is a pathological state resulting from a relative or absolute lack of an individual nutrient. Burden of disease in Pakistan. The double burden of malnutrition is becoming increasingly apparent in the country. Almost 1 in 3 children are underweight, which is 28.9%, alongside a high prevalence of overweight, which is 9.5% in the same age group. Enough is not known about the dimensions of the problem. On a global scale, the 5 principal nutritional deficiency diseases that are being accorded the highest priority action are kwashiorkor, marasmus, xerophthalmia, nutritional anemia, and endemic goiter. Principal nutritional deficiencies. It is divided into macronutrient malnutrition, also called the protein-calorie malnutrition, and micronutrient malnutrition. The macronutrient malnutrition includes kwashiorkor and marasmus, and micronutrient malnutrition includes vitamin A deficiency, iron deficiency anemia, and iodine deficiency disorders. These 5 disease states represent the tip of the iceberg, and much larger population is affected by the hidden burden of disease. Etiology of malnutrition is divided into primary malnutrition and secondary malnutrition. The causes of primary malnutrition includes ignorant and erroneous food habits, low income and low purchasing power, scarcity of food supply, and overpopulation. And the causes of secondary malnutrition includes infections, particularly respiratory, diarrhea and intestinal malabsorption, congenital defects, and metabolic disorders like insulin resistance and diabetes. Concept of food gap. The protein energy malnutrition is primarily due to inadequate intake of food gap, both in quantity and quality. Infections, most notably respiratory infections, diarrhea, measles, and intestinal worms, which increase requirements for calories, protein, and other nutrients while decreasing their absorption and utilization. It is a vicious circle, infection contributing to malnutrition and malnutrition contributing to infection, both acting synergistically. This figure shows the malnutrition infection cycle, which starts with inadequate dietary intake, leading to weight loss, growth faltering, lowering of immunity, and mucosal damage, which leads to disease causing appetite loss, nutrient loss, malabsorption, and altered metabolism, which ultimately leads to inadequate dietary intake. Web of causation. There are numerous contributory factors in the web of causation of malnutrition, like poor environmental conditions, large family size, poor maternal health, failure of lactation, premature termination of breastfeeding, and adverse cultural practices. Malnutrition is self-perpetuating. A child's nutritional status at any point of time depends on his or her past nutritional history, which may particularly account for the present status. To some extent, this nutritional history is linked to the mother's health and nutritional status, which in turn has been influenced by her living conditions and nutritional history during her own childhood. This figure shows the influence of each generation's nutritional status on the following generation, and it starts with the nutritional status of women of childbearing age and her nutritional status when she was pregnant and nutritional status when she was lactating, and neonatal and infant nutritional status, the girl's nutritional status, and nutritional status at puberty. Measurement of undernutrition. In children, undernutrition is synonymous with growth failure. To get a measurement of malnutrition in a population, young children are compared with a reference population known to have grown well. Use of measurements of dimensions of the human body, such as weight and height, is called anthropometry. Three commonly used anthropometric indices are weight for age, height for age, and weight for height. The anthropometric indices correspond to three states of malnutrition. Weight for age corresponds to underweight, height for age corresponds to stunting, and weight for height corresponds to wasting. Each of the nutrition indicators is expressed in standard deviation units, z-scores from the median of the reference population, based on which undernutrition may be classified as mild, moderate, or severe. This is the classification of malnutrition according to Gomez, weight below percentage median weight for age, and 75 to 90% weight for age is categorized as grade 1 or mild malnutrition. 60 to 74% weight for age is classified as grade 2 or moderate, and less than 60% weight for age is classified as grade 3 or severe malnutrition. According to Waterloo classification, which is the z-score standard deviations below median weight for height, 80 to 90% weight for height is mild, 70 to 80% weight for height is moderate, and less than 70% weight for height is severe malnutrition. Underweight is a child whose weight for age z-score is at least 2 standard deviations below the median in the World Health Organization child growth standards. It is a composite measure of stunting and wasting and is recommended as the indicator to assess changes in the magnitude of malnutrition over time. It can result from either chronic or acute malnutrition or both. It is often used as a basic indicator of the status of a population's health. Evidence suggests that mortality risk of children who are even mildly underweight is increased. Stunting is a child whose height for age z-score is at least 2 standard deviations below the median in the World Health Organization child growth standards. Failure to achieve the expected height as compared to healthy, well-nourished children of the same age is a sign of stunting. It is an indicator of linear growth retardation that results from failure to receive adequate nutrition over a long period or recurrent infections. It is often used as an indicator of past growth failure. It often results in delayed psychosocial and cognitive development and poor school performance. Wasting is a child whose weight for height z-score is at least 2 standard deviations below the median in the World Health Organization child growth standards. Wasting represents a recent failure to receive adequate nutrition and may be affected by recent episodes of diarrhea. It indicates current malnutrition resulting from failure to gain weight or actual weight loss. Wasting in individual children and populations can change rapidly and shows marked seasonal patterns associated with changes in food availability or disease prevalence to which it is very sensitive. Severe acute malnutrition is a child whose weight for height z-score is 3 standard deviations below the median in the World Health Organization child growth standards, amid upper arm circumference less than 115 millimeters, or has presence of nutritional edema. It can be an indirect cause of child death by increasing the case fatality rate in children suffering from common illnesses such as diarrhea and pneumonia. Children who are severely wasted are 9 times more likely to die than the well-nourished children. Kwashiorkor is a form of protein energy malnutrition when the main cause is inadequate protein intake and low concentration of essential amino acids. It is a severe form of undernutrition which develops in individuals on diets with a low protein energy ratio. The main symptoms include edema, wasting, liver enlargement, hypoalbuminemia, steatosis, and depigmentation of skin and hair. Marasmus is a form of protein energy malnutrition when the main cause is inadequate intake of both protein and energy. It is a form of severe cachexia with weight loss as a result of wasting in infancy and childhood. The main symptoms include severe wasting with little or no edema, minimal subcutaneous fat, severe muscle wasting, and non-normal serum albumin levels. This figure shows the comparison between a child with kwashiorkor and marasmus. The kwashiorkor is prevalent in preschool children of 1 to 5 years of age, and marasmus is particularly common in weakened infants of less than 1 year old. Preventive measures. Number 1, health promotion. Measures directed to pregnant and lactating women, education and distribution of food supplements, promotion of breastfeeding, development of low-cost weaning foods. The child should be made to eat more food at frequent intervals. Measures to improve family diet. Nutritional education, promotion of correct feeding practices, home economics, family planning and spacing of births, and healthy family environment. Specific protection includes the child diet to contain protein and energy-rich foods. Milk, eggs, and fresh foods should be given if possible. Immunization of children as per EPI. Growth monitoring on growth charts, especially of all children under 3 years of age, and food fortification. Early diagnosis and treatment, periodic surveillance, early diagnosis of any lag in growth, early diagnosis and treatment of infections and diarrhea, development of programs for early rehydration of children with diarrhea, development of supplementary feeding programs during epidemics, and deworming of heavily infested children. Rehabilitation includes nutritional rehabilitation services via outpatient therapeutic feeding, that is ready-to-use supplementary food and ready-to-use therapeutic food, hospital treatment if medical complications arise, and follow-up care. Management of a severely acute malnourished child. The body of the malnourished child may have compensated for micronutrient deficiencies with lower metabolic and growth rates. Spontaneous refeeding may mask these deficiencies, so the nutritional rehabilitation should be initiated and advanced slowly to minimize these complications. This is the WHO guidelines of 10 procedures for treatment of malnutrition. Number 1, treat or prevent hypoglycemia. Number 2, treat or prevent hypothermia. Number 3, treat or prevent dehydration. Number 4, correct electrolyte imbalance. Number 5, treat or prevent infection. Number 6, correct micronutrient deficiencies. Number 7, initiate refeeding. Number 8, facilitate catch-up growth. Number 9, provide sensory stimulation and emotional support. And number 10, prepare for follow-up after recovery. The 10 steps are divided into 2 phases. The stabilization phase lasts from days 1 to day 7, and rehabilitation phase lasts from weeks 2 to week 6. When there are no medical complications, a severely malnourished child who has an appetite is given a standard dose of Rootuf adjusted to the weight. Guided by appetite, the child consumes the food at home directly from the package with the supervision from the caregiver at any time of the day. A child being treated for severe acute malnutrition generally requires a total of 10 to 15 kg of ready-to-use therapeutic food consumed over a period of 6 to 8 weeks. Refeeding syndrome. If excessive carbohydrates are given during the course of refeeding, there is an increased insulin level resulting in shifting of potassium, phosphate, and magnesium into the cells. The severe hypophosphatemia during refeeding produces weakness, rhabdomyolysis, neutrophil dysfunction, cardiorespiratory failure, seizures, altered level of consciousness, and even sudden death. Assessment of nutritional status. The nutritional status of an individual is often influenced by the adequacy of food intake, both in terms of quantity and quality, and also by the physical health of the individual. The nutritional status of a community is the sum of the nutritional status of the individuals who form that community. The purpose of nutritional assessment is to develop a healthcare program that meets the needs defined by that assessment, including evaluation of the effectiveness of such programs. A proper nutritional evaluation demands a multi-angled approach covering all the different stages in the natural history of nutritional diseases as shown. The natural history of nutritional diseases is divided into a period of pre-pathogenesis and pathogenesis, and this figure shows the methods of nutritional assessment and their relationship to the natural history of disease. In the stage of pre-pathogenesis, food balance sheets and dietary surveys are utilized to assess the nutritional status, and in the pathogenesis state, mortality data, clinical signs and morbidity, anthropometric studies, and biochemical studies are used. Nutritional surveillance is keeping watch over nutrition in order to make decisions that will lead to improvement in nutrition in population. It has three distinct objectives. Number one, aid long-term planning in health and development. Number two, provide input for program management and evaluation. And number three, give timely warning and intervention to prevent short-term food consumption crisis. This is the comparison between growth monitoring and nutritional surveillance. The strategy for growth monitoring is preservation of normal growth, while for nutritional surveillance, it is detection of undernutrition. The approach is educational and motivational for growth monitoring and diagnostic and interventional for nutritional surveillance. All infants are enrolled in growth monitoring and only a representative sample is enrolled in nutritional surveillance. Age is 6 months and continues monthly for growth monitoring, and representative ages are taken for longer intervals for nutritional surveillance. The nutritional emphasis is maintaining good nutrition in growth monitoring and detect malnutrition in nutritional surveillance. Early home intervention based on local knowledge is the response for growth monitoring, and nutritional rehabilitation, often with supplements, is the response for nutritional surveillance. The health system for checkup and possible brief food supplements is the referral for growth monitoring, and malnutrition rehabilitation, often in special centers, occurs in case of nutritional surveillance. This is the concise list of indicators of nutritional status. For maternal nutrition, the birth weight is used. Infant and preschool child nutrition, the proportion being breastfed, the proportion on weaning foods by age in months, and mortality rates in children aged 1, 2, 3, and 4, with special emphasis on 2-year-olds. If age is known, the age for height is used. Age for height or weight for age or height for age is used, and if age is unknown, weight for height, arm circumference, and clinical signs and symptoms are used. And for school child nutrition, height for age and weight for height at 7 years or school admission is used. The assessment methods include the following. Number one, clinical examination. Number two, anthropometry. Number three, biochemical evaluation. Number four, functional assessment. Number five, assessment of dietary intake. Number six, vital and health statistics. And number seven, ecological studies. It's time for the recent updates. This is the Pakistan Demographic and Health Survey from 2017 and 18, depicting the nutritional status of children in Pakistan. The indicator weight for age, it shows the 14% underweight children in the province of Punjab and 29.8% children are stunted in Punjab and 4% children are wasted. Ready-to-use therapeutic food formulations with functional food and nutrient density for the treatment of malnutrition in crisis. Ready-to-use therapeutic food spread has been highly effective in the treatment of malnutrition in those affected by disasters, since it does not require preparation and baking and has a long shelf life and sufficient energy to improve growth and weight loss. Soybean, such features may be crucial during crises such as wars and natural disasters. The present study aimed to design a high-energy and nutrient-dense, ready-to-use therapeutic food formulation. Soybean flour and milk protein concentrate were used as protein sources. Corn flour and sugar were employed as carbohydrate sources. Cacao butter substitute was used as the lipid source, and vitamin, mineral, beta-alanine, arginine, nigella sativa, and sesame seeds were used as a functional food. The experimental results of food safety at the determined intervals at the beginning and 45 and 90 days after the production showed acceptable values. The conclusion was that since the nutritional requirements are among the essential human needs, especially in the management of malnutrition in crisis, it is of utmost importance to prepare ready-to-use therapeutic food products in order to meet all human nutritional needs by facilitating the easy use of these products, particularly for the prevention of malnutrition and diseases. This is the WHO guideline on the dietary protein content in ready-to-use therapeutic foods for treatment of uncomplicated severe acute malnutrition. The composition of ready-to-use therapeutic food, the most common formulation of ready-to-use therapeutic food referred to as standard root of consists of 4 food ingredients, that is milk powder, peanut paste, vegetable oil, and sugar, and multiple micronutrients to provide a complete complement of vitamins and minerals. The choice of food ingredients may be adjusted depending upon local availability, cost, and acceptability, but the nutritional composition must remain the same. The nutritional composition of root of includes energy 520 to 550 kilocalories per 100 grams and proteins 10% to 12% of this total energy and lipids 45% to 60% of this total energy. The standard root of with at least 50% of protein coming from dairy products is recommended for outpatient treatment with severe acute malnutrition. Use of root of formulations with less than 50% of protein from dairy products for outpatient treatment of children with severe acute malnutrition is encouraged within research and evaluation settings. According to the Food and Agriculture Organization of the United Nations, it recommends that the protein in root of should be of adequate quantity and quality to support an average weight gain of 10 grams per kilogram of body weight per day for optimal recovery from severe acute malnutrition. The alternative root of formulations, milk is considered as the most expensive ingredient in standard root of. As such, it has been suggested that replacing dairy with alternative sources of protein can significantly reduce the costs of root of while maintaining the nutritional composition. According to UNICEF categorization, alternative root of formulations can be grouped into 3 categories. Number 1, renovation products that use a combination of alternative cereals, legumes, or grains as partial or full replacement to peanuts in the standard formulation, in addition to 50% protein sourced from dairy. Innovation products that use a combination of cereals, legumes, grains, and different sources of animal protein, for example, fish, egg, or insect protein, with reduced amounts of dairy or no dairy at all, and novel products that use a combination of cereals, legumes, or grains and added amino acids and or different amounts of added vitamins and minerals. Recently, these alternative root of formulations with different sources of proteins have been tested in several trials. It's time for the multiple choice questions. Number 1, a 35-year-old female with 4 children comes to the basic health facility with the complaint of recurring episodes of diarrhea during the last 6 months in all of her children. The doctor on duty while examining notices signs of growth failure. Of the following, the most likely condition the children are suffering from would be A. Stunting, B. Wasting, C. Kwashiorkor, D. Marasmus, and E. Mixed Kwashiorkor and Marasmus. The answer is A. Stunting, because it is indicated in the statement that the signs of growth failure were noticed over a period of 6 months. A researcher wants to assess the nutritional status of a representative sample of children in village A, whether it is good or bad, is better or worse than that of village B and C, and whether it is improving or deteriorating over time. The most appropriate means to carry out such an assessment in the community is A. Anthropometry, B. Clinical examination, C. Functional statistics, D. Growth monitoring, and E. Nutritional surveillance.
A.
The answer is E. Nutritional surveillance, because 2 communities, 2 different villages are compared. So nutritional surveillance is used in this. Number 3, a family health practitioner prescribes ready-to-use therapeutic food to an acutely malnourished child. In order to demonstrate the maximum effect, the quantity and quality of root of protein should be able to support an average weight gain per kilogram of body weight per day for optimal recovery from severe acute malnutrition is A 2.5 grams, B 5 grams, C 7.5 grams, D 10 grams, and E 12.5 grams. Anyone?
C.
The answer is D, because in the recent advances, it was shown that 10 grams average weight gain per kilogram of body weight is required for optimal recovery. Number 4, for an experimental study, a researcher wishes to propose an alternative route of formulation that employs a combination of cereals, legumes, grains, and different sources of animal proteins with reduced amounts of dairy or no dairy at all. According to UNICEF categorization, this alternative route of formulation can be grouped as A, alteration, B, combination, C, innovation, D, renovation, and E, novel. So the answer is C.
B. Combination.
No, answer is C, innovation. It was also described in recent advances. A young, anxious mother visits the primary healthcare facility and expresses concern about the lack of age-appropriate growth of her infant, who is currently at 6 months of age. The most appropriate means to detect early onset growth faltering in this child would be A, anthropometry, B, clinical examination, C, functional statistics, D, growth monitoring, and E, nutritional surveillance.
B. Growth monitoring.
Yes, answer is D, growth monitoring, because individual child is concerned in this. 6, a newly emerging researcher with prime interest in working for child nutrition is puzzled by increasingly similar concepts of growth monitoring and nutritional surveillance. Of the following, one indicator not included in the concise list to demonstrate the nutritional status of a community is A, birth weight, B, neonatal mortality rate, C, infant mortality rate, D, under 5 mortality rate, and E, mid-upper arm circumference.
B.
Yes, B is the answer. As I showed the concise list of indicators to show the nutritional status, it said that the mortality data from age 1, 2, 3, and 4 should be included. In an executive meeting for the update of specific recommendations for a reliable source of protein content in the ready-to-use therapeutic foods for treatment of uncomplicated severe acute malnutrition in children by World Health Organization, the recommendation for outpatient treatment with standard route of formulation is A, at least 50% of protein comes from non-dairy, B, at least 50% of protein comes from dairy, C, more than 50% of protein comes from non-dairy, D, more than 50% of protein comes from dairy, and E, less than 50% of protein comes from non-dairy.
B.
Yes, the answer is B, at least 50% of protein comes from dairy. A child is brought to the primary healthcare center with skin depigmentation and signs of severe wasting along with bilateral pitting edema. As a healthcare provider in the facility, the most accurate diagnosis of this child should be A, stunted, B, wasted, C, kwashiorkor, D, marasmus, and E, severe wasting. Severe acute malnutrition.
C.
Yes, C is the answer, kwashiorkor. The lady health visitor provides oral rehydration therapy to a child with some dehydration as a protocol for the secondary level of prevention. This intervention must have been given as a part of A, biological assessment, B, clinical examination, C, functional statistics, D, growth monitoring, and E, nutritional surveillance. The answer is D, growth monitoring, because oral rehydration therapy is given to a single child by a lady health visitor. A researcher comes to know that the most common formulation of Rootuf, referred to as standard Rootuf, consists of 4 food ingredients, that is milk powder, peanut paste, vegetable oil, and sugar, and multiple micronutrients to provide a complete complement of vitamins and minerals. The choice of food Ingredients may be adjusted depending on local availability, cost, and acceptability, but the nutritional composition must include at least 8, 10 to 12% of total energy from carbohydrates, 10 to 12% of total energy from proteins, 10 to 12% of total energy from lipids, 10 to 12% of total energy from vitamins, or 10 to 12% of total energy from minerals.
B.
Yes, the answer is B, 10 to 12% of total energy from proteins. This is the key for the MCQs. Please like, subscribe, and share our YouTube channel. Thank you very much.
Thank you very much, Dr. Ramsha. Very nice presentation, and it is one of the very important topic, malnutrition, as we are in Pakistan still struggling with one of the meanness that has been caused by malnutrition. And in 2023, we are very hopeful that the number of stunted growths and wasting would decrease if there are no disasters like floods and etc. As we are moving forward, we are looking towards a generation that is healthier than before. And for this is the most important topic that has to be promoted by each and every person in community medicine, preventive medicine, and any doctor who can play their part in improving the policies, especially that are related with our population. So it is the topic that is very close to my heart, and I always advocate about the proper nutrition. And we have established a desk of diet nutrition to spread the message of nutrition in each and every corner of not only Pakistan but also in other countries through our expatriates. The second important thing is about the research that we have recently conducted, and I am very glad that Dr. Ramsha, Dr. Sadia, and some of other our students are playing a pivotal role in that nutrition on RUTEF and RUSEF. RUTEF is ready to use therapeutic food and ready to use supplemental food. I want each and every student who has been studying in Department of Community Medicine, King Edward Medical University, must be an advocate of RUTEF and RUSEF diets so that they can play an important role in decreasing the whole problem of malnutrition. And as far as these slides are concerned, the presentation was very good. It was a well designed, well prepared, and well organized presentation. Especially the most important part is the scenario based MCQs. With all the important aspects have been covered very nicely, especially when we see the root of the four pillars that are necessary for it, that we have to cover carbohydrates, proteins, fats, minerals, antioxidants, and it has been very beautifully covered. And we know that even the very cheap things like peanut uh, and sugar and some of very important things like milk for calcium has to be advocated in order to decrease the malnutrition and to promote the growth of our children. Another important point is about the growth charts. As correctly has been mentioned, that growth has to be monitored continuously in order to monitor the effectiveness and efficacy of root and elusive diets. Another important thing is that whenever we are talking about any disaster, especially in conditions like floods, these things they do help, and we have seen many people have been given these diets free of cost, and they have improved their well-being as well as their livelihood. So it is not only the saving people from malnutrition, but it is actually saving people from death. I am so glad that all these aspects has been beautifully covered. Thank you very much, and see you next time. Very well done, Dr. Ramsha. Allah
Thank you
Hafiz.
very much. Thank you very much, ma'am. Thank you very much. Hafiz. Assalamu alaikum, ma'am.